Pleasure to talk about this topic. This is not a sexy topic. This is not critical care. This is not saving lives, but it is very important to our well-being as emergency physicians, and it is something that I think is a learned skill and something I want to share with you today. So, being smart in emergency medicine is really just not enough. We spend an awful lot of time training residents and training medical students to think about things critically, but patients don't care about your board scores. They don't care about the most recent article that you read. I crossed that out because everyone's reading podcasts nowadays. What do they want? Well, they really want to get to know why they're there. So one of the pearls I have for my residents is find out why these people are in the emergency department. And you have to be a detective. You have to listen. You have to ask them. And a lot of times you find out that it's really not for something that's acute, emergent, that you can actually fix and stop. These are some chief complaints you'll see when I see them. Initially, my kind of gut sinks, and I'm like, I don't know if I'm going to be able to help any of these things. Chronic abdominal pain outside hospital, knee pain for 4 weeks. So I hate to say it to y'all, but this is not what you signed up for, unfortunately. We saw these TV shows. I put myself over there in St. Elsewhere. That's how old I am. That's my cohort. Depending on how old you are, that's what you got excited about. That was kind of the idea of emergency medicine. And we're not well sometimes because we don't realize that that's not what we're taking care of. Take this 27-year-old. It's brief, chest pain, tingling, bilateral hands. You've heard about the PERC score. This PERC score negative. So then the question comes, what are we going to do? And this is how my conversation with the residents go. None of the residents that are here, because they're awesome, but some other residents are like, so what do you want to do with this patient? Well, it's pretty low risk. Well, what do you want to do? I don't know, nothing. Well, everyone gets something. That's another rule of the emergency department. So what are you going to do? Reassurance. Well, what is reassurance? How do you go about reassurance? And I'm here to argue that there's a specific, deliberate way that you can do it. And it's taken me a long time to figure this out. It took me a couple years even as being an attending before I confidently felt like I was able to do this. But words really matter. And I want you to be able to harness the power of reassurance so that you can basically apply this in the right setting. Because there is a right way to do this, no different than a central line or an intubation or anything else. Patients don't want to hear about probability. They don't want to hear about resource utilization. They don't want to hear about antibiotic stewardship. But they do want to know what you would do if you were taking care of a family member. They do want to know that you care and that you listen to them. So how do you message reassurance? How do I go about that? And I'll give you a few scripts and tell you a few of the ways that I've developed this. One of them is the reluctant patient who does not want to go home. Like absolutely just does not want to go home. And I say this, you know what? I'm the kind of doctor that has to be honest with you. I'll be honest and tell you if I'm really worried about you and there's something wrong with you. But I'll also be honest with you if I've done some tests and I haven't found anything. And luckily, it's going to be okay to let you go home. Another one is the terrified, life-threatening diagnosis. This is always, the challenge when the patient comes, and this will be up next, but the patient is sent in from urgent care, and they're sent in specifically to get CTLP rule out subarachnoid hemorrhage. So this is the script for that. I've had many years of experience. There's nothing in your history and exam that tells me that this is something dangerous or bad, and we're going to let you go home. And I know that you're scared and concerned. I want to listen and make sure that you're doing okay. Bell's palsy. There's a time I would, do CT scans and give reassurance, through test ordering. But sometimes the best thing to do is look patients in the eye, say it with conviction, and convince them that they're going to be okay. Because 95% of the time, 99% of the time, your gut is right. Sure, we can use PERC score and we can use pneumonia severity index and we can use a whole lot of tools, but a lot of times it's your words that are the most powerful thing to help your patients. So, I want you to be purveyors of reassurance. I want you to understand that that's what we do. Think about the two different texts here. I think the probability of this being an ischemic event is very low, but we're going to get some imaging to check. Patients don't know what that means, versus there's nothing on your exam to suggest that this is a stroke. You're going to be okay. Sometimes you look at this board and you're like, I don't know if I can get through this day. Massive virus. This is me. Sometimes when I have a man cold, and I've learned that the best way to deal with this is I have a special blue sweater and I put it on and it makes my family give me special attention. So that's my approach at home. But we do have some of these scores. We need more. We need more research to do optimal risk stratification. We need to dial some of those risk stratification tools into our EMR. We need to make our life easier to do the right thing because your heart is there. You want to take care of these patients. And I know it's sexy to do so with a lot of fancy tests and a lot of critical care stuff. But a lot of times what we're doing in the emergency department day in and day out is reassurance. So develop your tools, listen to people who do it well, and develop your tools as a master clinician. Thanks.
Thank you so much. Nick Kamen, you're up. Judges?
So that was a fantastic distillation of many years of clinical experience, it sounds like. And I want to remind the audience about two of things you said. Words matter. Our words do matter, our patients. They don't care how smart we are. What they care about is how you make them feel and how they feel. And I think that summative point of your talk really gives a lot of credence to what we do and how we make patients feel, because they don't care how much they spent in the emergency department. Many of them aren't going to be able to pay that bill, but what they care about is how they feel when they leave. So thank you so much for something you're passionate about. Thanks.
Thank you.